I want to, the chief residents run these and host these. I just wanted, though, to take a moment and say welcome to our first academic half-day session. And for those who are not familiar with it, for the interns who haven't experienced, academic half-day is really our key didactic opportunity for everyone who's on a non-admitting block or non-vacation period. And this is your chance to spend a concentrated amount of time learning. And we pay for this time. So this is a luxury in our program in that we are paying your stipends just so that you can learn during this time. I will be, as I transition to the new role, I will be starting to hand off some of the responsibilities to the actual running of this. But I will say that this has been my favorite activity that I do on a day in, day out basis for all of you guys, how much I love this opportunity to get together and learn from one another and see each other. To that end, one thing that was communicated via email, and just to say it out loud, is that um, we are moving towards more of these sessions being in person. There's a little bit of an issue that we're running into because classroom spaces are tight. We're trying to follow a general pattern for when one of the sessions will be virtual. It will generally be um, the Thursday after seniors switch. I think that translates into week number 2 or 3 for interns. But it's not going to be perfect because classrooms are going to be what they are and all that sort of stuff. You're also going to see that the locations will be changing, so please pay attention to those emails. We're aware that it's sort of annoying to always have to pay attention that the locations are moving. Know that that's something we're working on, and it is imperfect. But I so enjoy getting a chance to see all of you in person and meet with you. And next week, for our first in-person session, it'll be at the VA. I'm going to spend a little time. It's a Ask Me Anything session. I'm going to spend a little time just telling you a little bit about myself so that you can know who your new program director is. And then I'm going to leave the whole rest of the time for just open forum and conversation and discussion. And if people don't have a lot to ask, I'll bring some of my game cards. Those of you who know my game day, I'll bring those. We can play some games together. We'll do whatever, and I'll bring some snacks. And if nothing else, we'll just have some fun. But I appreciate you all being here, and I appreciate that the chief residents for all the hard work they help in doing this. And just again, want to say how much I really love this session and hope that you do too. And with that, I'm going to stop and let the day run.
Awesome. Thanks, John. So we've got an awesome lineup. To start off, we have David Rink, who is the current UW MC chief. Hopefully you guys all have gotten to know him a little bit over the past few months, couple years for those who are have been here longer. And the only little tidbit that I'll add is that David was a chess champion from 5 to 8 years old. And so when you get a chance, you should challenge him at UW and send everyone the results of who won. I'll hand it over to you.
I don't know where Will gets his facts, but I love it. Thanks, everyone. Let me, as I'm pulling up my slides here, yes, I hopefully have met most of you, particularly our new interns. And of course, many of you now have the pleasure of knowing me through the 5 a.m. risk pages, for which I apologize dearly. Just know that that also ruins my day. Though I don't think it ruins it as much as it ruins yours. So I have that much self-awareness. So in any case, really appreciate all of y'all. And thanks to John and Rini and Will and Gina in absentia who have allowed me to take the first session, which is crazy. I don't know why they trust me with that. I'm gonna ask Rini, Will, somebody, can you guys just keep an eye on the chat for me? Sweet. And then also keep an eye on the time for me because I can talk a lot. So this morning I wanted to talk to you guys about long QT syndromes, and for anyone who gets the reference, great. For anyone who doesn't get the reference, we're referencing a 1960s movie, which is really a huge throwback and tells you all you need to know about me. And we'll just kind of jump in from there. I have, let's see if we can get this to roll. Great, no disclosures. Or at least certainly no financial disclosures. I am not an expert in this topic. I did consult with experts in creating this talk, though, so hopefully I'm able to give you guys a good some education around this. And we're still not advancing. Great, we got to click. All right, learning objectives today. So we're gonna contrast the physiology of the normal QT interval with the pathophysiology of torsades. We'll evaluate the challenges in defining and measuring a normal QT interval. We will compare the characteristic clinical features of congenital and acquired long QT syndromes. And then we're going to hopefully, sort of as an overarching goal, grow your clinical comfort level with prolonged QT intervals by developing what I would call a partially evidence-based strategy for risk stratification and then minimization in those who have long QTs. And to begin, I'll start with a case that many of us are familiar with, and that is you get a page or maybe an Epic chat these days from one of your nursing colleagues who says that your patient is nauseous and they're wondering if they can get an order for some antiemetics. You are the cross-cover resident and you happened to dig through her chart and notice that, hey, she got an EKG when she came in. That's great. The EKG is telling you that there is a QT interval of about 500 milliseconds. And I would like to know, and we can just use the chat for this, what would you guys do? And you're welcome to choose one of these answers or any other answer.
We do have a poll if you would like to use it.
Sure. If it's that easy, let's do it. Wow.
I just want to call out, because I didn't before, Javel Cullen in our residency program office, expert in everything Zoom and everything related to academic half day, and thank her for her help.
Thanks, John.
Sorry if my mouse is going crazy. I'm trying to organize my screens. All right, look at this. We got a whole mix of things. So yeah, about a quarter would give the patient some Zofran or ondansetron, another quarter with prochlorperazine, another third or so would try the alcohol swabs. That's great. That means maybe some of you guys have actually heard about that. But really a smattering of answers here, which is exactly what I was hoping for. Playing exactly into my plans, everyone. Thank you. So we're going to set that case aside, and we're going to look at this, which is an actual case report that I found. And this was a young woman who had a past medical history of depression. She's on fluoxetine. She presented to the emergency department with 3 days of intractable nausea and vomiting. She is clearly retching in the room, and she was immediately given a dose of IV ondansetron, 8 milligrams. 15 minutes later, she's still retching. She gets 10 milligrams of IV metoclopramide. Labs that were collected on admission come back. She has potassium of 2.6, a magnesium that's less than 1. And we'll just say that you're in this role, and somebody is kind enough to hand you the EKG that they got on just got on her. Which, as you look at, you notice has this short run of what looks like a non-sustained polymorphic ventricular tachycardia. The computer is telling you it has a QTC of 680 milliseconds. You order her some stat electrolyte repletion, but as that's just getting going, she loses consciousness. You palpate a pulse and, or you are unable to palpate a pulse and have to start ACLS. And I'll just say that this is in fact a real case. It sort of highlights the extremes of what it is we're really talking about here today, but it does hopefully drive home the importance of why we care about this, because I think sometimes this becomes very rote, and it's important to remember that this is a real clinical entity that does truly affect people and can result in morbidity and mortality. So with those two cases as background and just sort of things to keep in mind, we're going to jump into some actual background here on the QT interval. And so as a reminder, for those of us who are far away from our physiology and electrophysiology, the QT interval represents the time delay between ventricular depolarization and subsequent repolarization of the ventricular myocardium, as you see there on the right, illustrated by the green box. From an electrophysiology standpoint, it is the time between phase 0 and the end of phase 3, if you average that across all of the myocardium. This period corresponds to the balance between the outward flow of potassium and the inward flow of calcium. Not a thing I think about on a day-to-day basis, but I think it's relevant just to be aware of what's going on at the cellular level. A question for you all as we get more clinical, and if we could use the poll again, that'd be great, Javel. What is a normal QT interval? Great. So a couple people were willing to commit to some numbers, but it seems like most people are saying, hey, are you tricking me? There's something else we have to do here. And I think, as you'll see, as we sort of discuss, this is less straightforward than you might think in terms of defining what a normal QT interval is. And so first, to start with those last 2 points. So it is important to know that this heuristic you may have heard of less than 1/2 of the RR interval, being a normal QT interval, is first of all a heuristic, and second of all, only really relevant and appropriate to use in patients who have normal heart rates with otherwise normal-ish EKGs. If you use this technique in people who are tachycardic, it will make the QT appear falsely prolonged, and then bradycardic, it makes it appear falsely shortened. Now, regarding the question of correction, it is true that we typically use a corrected QT interval for heart rate primarily. And what is also important to know is that there are like dozens of formulas that have been created for this, and there is no gold standard. The most common one we know of or teach really is Bazette's formula, as you see here, where you take the uncorrected QT interval and divide it by the square root of the RR interval. Not a thing many of you guys have probably thought about on a day-to-day basis. But just know, and this is actually what many of the machines use, although there are different standards and different formulas that some machines do use. But just know that the Bazette formula in particular falls apart at faster heart rates, and there are a number of alternatives. Some of them you may hear cardiologists talking about, like Hodges, Framingham, Frederica. Almost all of them have actually been shown to be more accurate than Bazette's formula, but again, no gold standard, and Bazette's tends to be the easiest one, which is why we often use it. Other difficulties in defining a normal range of values for QTC actually come from the fact that there's inherent intra-individual variability of the parameter, and then there's limited frequency and timing of observations. So there are actually Holter monitor studies of patients that have noted intra-individual ranges as high as 95 milliseconds. So that is one person whose longest and shortest QT are 95 milliseconds apart. We don't really understand this intra-individual variability totally. However, there does appear to be at the very least diurnal variation in the QT interval, where mornings tend to be longer than at night. Additionally, we know there are inter-individual variations, which include age, sex, or sort of hormone balance. Generally, what we see is that the QT interval will lengthen leading up to puberty. And then with the increase in female sex hormones, it will prolong further. We've actually demonstrated this, or it's been demonstrated in both cis and transgender populations on feminizing hormones. So clearly these variations make it really challenging to define or determine what a normal QT interval is, and particularly with what to do with a single measurement. That said, we do have to make a decision clinically how to use this. And I would say there are no guidelines about what a normal QT or QTC is. But if you look this up, you'll find most people will cite numbers around this range. And I think the most striking thing when you look at this table is probably, particularly for anyone who's sort of been doing clinical medicine for even a couple of weeks, you'll note that we oftentimes don't really start to care about the QT interval until it gets to be 500 or longer. And in many cases, I wonder if some of us would even think of calling somebody's QT interval of 460 as borderline. That said, if you really look into the literature or any sort of clinical reference, that tends to be what is cited. Why do we care, though? And I think the initial case that I presented is the main reason why we care. And that is that torsades, as we understand it, so polymorphic ventricular tachycardia, is the universal risk factor for torsades, rather, is a prolongation of the QT interval. There is no torsades without a prolonged QT. You cannot find that in the literature. This is the clear precipitating risk factor. I will say that most people who have torsades, it tends to terminate spontaneously, often after causing syncope. And so prolonged QT syndromes causing cardiac syncope is a very common presentation. However, it's important to note that this can also lead to sudden cardiac death. There are estimated incidences somewhere around 4 per 100,000 annually. However, the majority of experts in the field believe this to be underestimated due to lack of reporting, out-of-hospital deaths, and the fact that for a long time there was not even an ICD code for this. Mechanistically, when we go back to thinking about the electrophysiology, so the electropathophysiciology here, torsades is what we call a triggered arrhythmia, which occurs due to these early after depolarizations, which you can see there on the action potential as that upward deflection where it would normally be returning to a baseline. And what you can see clinically if somebody is on telemetry or cardiac monitoring is episodes of torsades are frequently preceded by this short, long, short interval of heartbeats. So it's worth looking at the next time your patient maybe has an episode of non-sustained VTAC to see if you see that, because that could be indicative of a prolonged QT that maybe you hadn't picked up on earlier, again, related to some of this variability in our measurements. I think the most interesting question here is really when we should be concerned, though. Again, we talked about earlier how we define what a normal QT interval is, and even those definitions don't seem to match up with what our clinical practice is. And I think we are all appropriately concerned about the risk of torsades. Like I've never really run across people who don't seem to care about that. But I think it's really hard to define sort of what our thresholds are here. And it is that by and large inspired me to do this talk. And I will say that the massive caveat to the talk in general is that it will be only partially answered. But we will do our best. As it turns out, a lot of people have written about this and how frustrating this is in the literature. And so this is from one paper wherein this author, Dan Roden, was saying how frustrating drug reactions are, particularly when they're idiosyncratic and unpredictable, and that torsades and QT prolongation is the most common reason for that. The risk associated with the prolonged QT interval, though, and the development of torsades has been described with this concept called the repolarization reserve. And as I looked through the literature and talked to some of the electrophysiologists, this was probably the most like relatable, easy to understand, digestible reason I could come up with for why some patients experience this and others don't, and seems sort of the most clinically relevant to us. And essentially, the repolarization reserve postulates that repolarization is modulated by multiple partially redundant mechanisms. And so when one determinant of repolarization is abnormal or inhibited, repolarization and therefore the QT interval may actually remain normal or close to normal. However, when there are additional perturbations in this, repolarization reserve then becomes diminished, and that is actually what probably results in QT prolongation and increasing the risk of torsades. And there's in vivo, or rather, there's lab-based studies, sorry, of cardiac myocardium that have sort of demonstrated this, as you can see there, where they're sort of partially blocking different ion channels. And then when they actually block both or two ion channels, you see more prolongation. And so in general, when you try and apply this to the patient in front of you, you can think of all of those purple boxes basically as reasons that somebody might be at risk with this repolarization reserve. And as you start to add multiple hits, you would then see more clinically relevant QT prolongation. Now, just how at risk people are with long QT syndrome is also really challenging to define, but probably is the most important question to us, is like, what is the number I should care about? And I will say this data is really challenging to interpret because the only data we have is in people who have known genetic long QT syndrome, or at least the only good data we have. And it's difficult to extrapolate genetic long QT syndrome with folks who do not have that diagnosis. That said, I think these Kaplan-Meier curves are pretty telling, which estimate the cumulative probability of any cardiac event, so syncope, aborted cardiac arrest, or long QT syndrome-related sudden cardiac death, on the basis of their corrected QT interval. And as you can see, the risk increments pretty significantly as you increase the QT interval. And particularly if you key in on, say, somebody whose QT interval is less than 500, whose cumulative probability over time is maybe about 30%, up to somebody who's greater than 550, and their cumulative probability is about 50%. So close to doubling of the risk for that 50 millisecond increment and corrected QT interval. And from that same study, it is pretty well recognized that an absolute threshold of risk can't be proven, but it's also apparent that actually the reported cases of torsades in particular in individuals with a measured QT value exceeding 500, or 92% rather of cases of torsades occurred in those whose QT interval was greater than 500. So 107 out of 116 cases here, you had a QTC interval greater than 500. And I think that sort of data is what is most commonly extrapolated to give us that threshold that I imagine many of us have heard when working on the wards or thinking about QT prolonging medications. But I will, again, reinforce that these data are in patients who have congenital long QT syndromes. And so it's really hard to know how that applies to our patient population, who we don't know have that. So I want to review quickly the background, and that is basically just to say that the QT interval is a really fickle thing. We can use things like Bizet's formula to try and get a better sense of this. But there are other ones. Prolonged QT is definitively the primary risk factor for torsades. We can probably explain torsades risk via this repolarization reserve concept. And then we can probably state fairly confidently that risk does scale with increasing QTC, and likely 500 milliseconds is a reasonable threshold for concern. I want to pause right there to make sure there's not any questions before I jump into the next section. Did I miss anything, guys? I'm going to take that as a no. Great. All right, so we'll talk about measuring QT interval next. And I will open this by saying that it's not actually that easy. You would think it would be, but that's not the theme of the talk. So I will say that it is pretty widely recognized that typical measurements of the QT interval in any individual subject are really cause substantial variability that cloud interpretation. So this variability, as we've already discussed, may be related to biologic factors, diurnal effects, differences in autonomic tone, underlying baseline variations in electrolytes or drug dosing. There's also technical factors, including the environment, that play a role here, and the actual acquisition of the EKG. So thinking about EKG quality And then features of the EKG. So what is the T wave morphology? Are there irregular rhythms or the presence of U waves? And any of these things can confound our measurement of the QT interval. I think one question that I asked a lot, and I imagine many of you do, which is like, when can I just look at the number on the EKG? When can I trust that? And I will say the answer to that was also really frustrating when I asked around. And the answer is basically it depends on who you ask. Some people told me you should never trust the EKG. Others told me that a more reasonable approach is that an EKG that has a relatively normal morphology and things look relatively normal on it, the computer does a pretty darn good job. But where it breaks down is when things are abnormal. And abnormal could be, again, irregular rhythms, a baseline wide QRS, paced rhythms for sure, any sort of noisy baseline, T-wave morphologies that are out of the ordinary, U waves, and then particularly abnormal values. So where all of these things break down is when we get really short and really long. Which then begs the question, if we can't trust the EKG, how do we do this? And I want to be clear, I'm not advocating that you break out the calipers every second of every day and try and measure your own QTs on every patient. But when it really matters, when you're really concerned about a patient, maybe because they need QT prolonging drugs and they're on, and they already have a baseline prolonged QT, like this is the time where it matters to double check things. And so how do you actually manually measure this? Ideally, you want to measure in several successive beats. You want to identify the beginning of the QRS complex and the end of the T wave. And for the latter, the technique that is usually recommended is called the maximum slope intercept method, which basically means, as you see here, that you draw that red line along the maximum downslope of the T wave, and wherever it intersects with the baseline is where your end point is. And you can see a couple of examples there on the right where there looks like there might be U waves. And we'll talk about what to do with U waves later, but I think this illustrates the approach essentially, which is if it looks to be a more distinct U wave, you kind of ignore it, whereas if it's more involved or more included in the T wave morphology, you include it. Next question for everyone. Where should you measure this? In what lead? Great. Most easily discernible, lead with longest QT are the most popular answers. And I would say I generally agree with that. There's not actually any like guidelines or expert consensus recommendations here, but I think those are the like common sense answers. Every once in a while, I feel like I've heard somebody be like, oh, it's best to do it in 2 or V5 or something. And I can't find any evidence to support any of that. And so I totally agree. Wherever you see it most clearly is a great place to do it. And then in particular, if one does really look the longest, it really should all be kind of the same, but sometimes based on the morphology of the actual leads, it's a little bit more clear where the end is and it's longer. So maybe choosing that one is the right answer. Couple specific scenarios that we should address. Probably the most common one of the most common ones. What if the QRS is wide? So what if they have a baseline conduction delay or bundle branch block? So by definition, a wide QRS will lead to an increase in the QT interval. That's because the QRS is included in the QT interval. However, most experts do not believe that to be a clinically significant prolongation of the QT. So there are a couple of approaches here. The first is to consider using what they call the JT interval, as you see there. So using the J point where the QRS ends and the ST begins to the end of the T wave. And in that case, you correct the same way. So you use the JT, so like the Bezet's equivalent is the JT uncorrected over the square root of the RR interval. And in that case, a threshold of about 330 milliseconds is greater than that would be considered prolonged. You could look this up again, just know it's a thing. Another approach is to just subtract however much the QRS is prolonged by, and subtract that out from the uncorrected QT, and then correct. So say your QRS is 150 milliseconds instead of like 110, or 120, I guess would be the threshold of normal. Subtract 30 from whatever the QT interval is. So 150 minus 120 of a normal QRS is 30. Take that out of whatever your QT interval is, and then correct. Either one of those approaches is a reasonable one. And again, you can look this up, but I think it's important to know that a baseline wide QRS morphology is going to prolong your QT, and it's probably not a clinically significant prolongation. That said, they could have an underlying prolonged QT as well, so that's why you still have to do it. Another one that comes up is an irregular rhythm. I think we see a lot of irregular rhythms, and I will say that you cannot trust the QT interval on an EKG of a patient who has AFib. You just can't do it. So you have to, if you're worried about prolonged QT in this case, you have to calculate it yourself. There's a couple of approaches here as well. So the thorough approach is that you actually measure and calculate the QTC for 10 successive beats and average them. A more realistic approach might be that you try and find the shortest and longest RR intervals and calculate the QTC for each of those and average those. In any case, the take-home point here is that the EKG calculation will be wrong for an irregular rhythm. Other things that come up, paced rhythms. I would say paced rhythms are a little bit complex, and there's a lot of different suggested approaches to this. The good news about patients with paced rhythms, sort of two pieces of good news. The first is that they usually have a cardiologist who you can lean on to get help if you're worried about a prolonged QT interval in this patient population. And the second thing, which is not like a way to practice medicine, but sometimes it's nice to just reassure yourself, a lot of these patients have ICDs. And so, you know, it just sort of lowers the overall risk. But really just lean on their cardiologists. U waves are somewhat common, and what should we do with them? So this is not really clear whether there's clinical significance to the U wave in terms of whether it should be incorporated as lengthening the QT interval. I think the most common approach I heard of from different cardiologists was basically if it really seems like it's part of the T wave, to include it. And if it's more distinct from the T wave, then to not include it. That becomes a little bit of a judgment call. And it probably wouldn't be wrong to, again, talk to a cardiologist in this case if you're really concerned about a patient, to just kind of get their advice. All right, quick review on this section. The QT interval is hard to measure. It seems like it should be easy, but it's not. And just know the limitations of the computer and recognize that we can measure this ourselves. And this is probably the most important thing, to measure ourselves on an EKG when you're worried about a patient's, it may modulate their risk for something like torsades. Okay, another brief pause for questions. Still nothing? Great.
Excuse me.
Yeah.
Can you just show us how to do the measurement again? Sorry, if you
Oh, yeah.
don't mind.
Yeah, of course. Let me jump back to that one. There you go. Yeah, so to actually determine the QT interval, the uncorrected QT interval, you want to choose the start of the QRS. And then you use this technique called the maximum slope intercept again, where you see that red line drawn on the downslope of the T wave and where it intersects with the baseline. And so that intersection of the sort of red and blue lines there, and apologies for anyone who's red-green colorblind, that is really not fair to you. But essentially that intersection is the end of the QT interval, the uncorrected one, and you then take that uncorrected number. If you're going to use Bizet's formula, the most common one, you'll divide that by the square root of the RR interval of the preceding beat. And I want to be clear that this is something you can totally look up. Like, you don't need to have this memorized. I think there's not really value in it. Nobody's going to be like, quick, calculate this without looking it up. But I think it's just important to be sort of explicit that this is the approach that is recommended.
Okay, thank you.
Yeah. All right. So now I just want to take a minute to talk about long QT syndromes. And classically, long QT syndrome is divided into congenital and acquired. This may represent an artificial dichotomy, though. Congenital long QT syndrome represents all those with an identified genetic channelopathy, but those with acquired long QT syndrome who eventually develop a life-threatening arrhythmia quite plausibly carry a genetic predisposition that we just haven't identified. I think that's a really important point here. Because we see a lot of long QTs and it's unclear whether or not those are acquired, sort of iatrogenic, or if perhaps these are people with unidentified syndromes. The currently identified congenital long QT syndromes consist of 13 or more distinct genotypes, and these are just called long QT 1 through 13, basically. And then there are two classical clinical phenotypes, which are differentiated by the presence or absence of deafness, which I think, if I'm remembering my hearing physiology, also probably has to do with ion channels. Interestingly, congenital long QT syndrome is not a monolith. And so these are the three most common congenital syndromes. And what's quite interesting is what actually triggers their arrhythmia by genotype. So those with long QT syndrome type 1 are most commonly experiencing triggered arrhythmias in the setting of exercise, whereas those with 2 and 3 most commonly experience that actually during sleep. And then diagnosing long QT syndrome, it turns out, is like really challenging. This was a study that looked at diagnostic concordance in a referral population to a long QT syndrome specialty center. And it demonstrated that about 40% of patients who were referred actually did not have long QT syndrome. I really like the conclusion that says 2 of every 5 patients referred with a diagnosis of long QT syndrome departed without such a diagnosis, which is a really nice way of saying that the referral was wrong, but which doesn't mean that we shouldn't be looking for it. It just means that it's more challenging, I think, than we realize, and this is why we need our specialists. When should we, though, sort of the maybe more frontline physicians, as internists, be thinking about this? Important things to consider in history. So anyone who has a personal or family history that includes cardiac syncope, sudden cardiac death, unexplained car accidents or drownings should certainly raise your suspicion for an occult arrhythmia, of which long QT syndrome is one. When should you specifically suspect it at that point? And normally prolonged QTC in the absence of secondary causes really should make you think about this. There aren't really clear guidelines. This is sort of one approach of stratifying. And as you can see towards the top, based on, again, male and female, and that's really referring to, again, the sex hormone balance. The longer the QT gets without secondary causes, the more likely you should be considering this diagnosis. But there's no hard and fast rules here. If you are thinking about it, what should you do? You should start with a thorough investigation for secondary causes. And I think most of us know a lot of these, particularly the medications and electrolytes. Other things that can prolong the QT, though, are thyroid disorders. Interestingly, starvation or anorexia can do so in the absence of electrolyte derangements. And then obviously myocardial ischemia or any sort of underlying other heart disease could do it. You should certainly take an extensive personal and multi-generational family history, again, looking for things like cardiac disease, arrhythmia, or arrhythmia syndromes like we just talked about. Arresting 12 lead EKG and maybe even needing to repeat it is worthwhile. And then there is this score, the Schwartz score, which you can start working on. However, I don't necessarily know that I have the expertise to comment on a couple of these things. For example, I would have to look up T-wave alternans to really see if I think that was present. But I think this gives you somewhat of an idea of what things are being weighted to consider whether or not diagnose or whether or not a long QT is consistent with a long QT syndrome. And when in doubt, obviously lean on your subspecialists. So referrals to cardiology and electrophysiology for evaluation is not going to be wrong if you're really concerned. The etiologies for acquired long QT syndrome, as we discussed, most people know pretty well from medication and electrolyte perspective. I would again harp on the thyroid. Other things that I didn't really know about was the hypothermia and the starvation, which are not things I tend to think about much in this setting. Obviously, if they're that hypothermic, there's probably other things you're dealing with, but just worth noting. And then just to comment on drugs, because I think this is a really important thing. So this was a review article from the New England Journal about 10 years ago, and they said that in the past decade, so the preceding decade from when it was published, the single most common cause of withdrawal of a drug from the market was aftermarket recognition of prolongation of the QT interval, which I think is pretty important when we think about it. I know this comes up a lot when we're thinking about drug therapy as internists, and so clearly this is on everyone's mind. By way of brief review, because I think you all know this already, what are the most common medications that prolong the QT interval that we deal with? So the highest risk one is somewhat intuitively, but also ironically, the antiarrhythmics, so class 1A and 3 antiarrhythmics. I would note that's probably not a side effect so much as a marker of efficacy. But the ones that have true side effects of prolonged QT are clearly our antiemetics, as well as antidepressants, certain antibiotics like quinolones and macrolides, antifungals like azoles, antipsychotics, and then methadone is one that we really have to think about a lot too, particularly in some of our populations. It's not an exhaustive list here, obviously, and you should always try and look this up for individual medications. Your pharmacists are very helpful here, but these are going to be the common ones we deal with. From an electrolyte perspective, I think we all do this pretty well too. So low electrolytes in general are going to be a risk factor for prolonged QT. I will note that there's some signal in the literature that sort of questions whether or not hypokalemia is actually prolonging the QT or just increasing the risk of torsades when the QT's already been prolonged. That said, you should replete the potassium regardless. All right, final review for the final section. So long QT syndrome is super important to recognize. Really thinking about adding it to a patient's problem list is a thing I do think we could do a better job with, and then considering a differential for it that is maybe more extensive than just replete their potassium. Always remember family history and thinking about unexplained syncope and death in patients connected or extended family. And then obviously thinking about the medication list and electrolyte abnormalities is very common things, but not forgetting things like the thyroid or starvation as etiologies. All right. I can jump into the last section unless there's any questions. How am I doing for time, by the way? What do I have? Like 2 minutes?
We can probably give you 5.
5? All right, let's do it. All right, wrapping up here. So I will just read this real quick because I think it's an important take-home point. And it says that the precise relationship between prolongation of cardiac repolarization and risk for serious ventricular arrhythmias remains unresolved. The clinical measurement of repolarization, the QT or QTC, is a highly variable parameter that does not closely correlate with risk for sudden death, perhaps because prolongation may occur by a number of different mechanisms of variable proarrhythmic potential. However, existing data suggest that the magnitude of QTC prolongation and characteristics of the population, in particular the presence of heart disease, are the most important determinants of risk for torsades and sudden death. So what is sort of the take home of what we can do about this? And I would advocate for this 4-pronged approach, which is 1, risk stratification, then risk minimization, thinking about monitoring, and then informed consent. So risk stratification is hard. Practically speaking, there's only so much we can do to identify risk and then play a role in it. I will say there are a number of risk stratification scores. So this is one called the Tisdale risk score you could find on MD Calc. It's specifically been validated in populations in CCUs, so coronary care units. So that's going to be a really small subset of patients we're routinely caring for. It may be reasonable to extrapolate it to anyone who's presenting with some form of decompensated heart disease, but probably beyond that, it becomes a little bit challenging. Another more simple one is actually this nomogram that's been developed based on data about cases of torsades. And in this case, they actually plotted the uncorrected QT interval against the patient's heart rate. And as you can see, based on the actual data on the right, essentially anyone below the line was at extraordinarily low risk for torsades. Other tools we can use, there's been some compilation of medications and data around QT prolongation. So Credible Meds is a source that lists QT prolonging medications. It also sort of links to studies about where this data has come from. I will say it's not as robust as it may sound like it should be, but it's one place you can go looking if you're interested. From a monitoring standpoint, I think we do have some role here. So the first is thinking about EKG monitoring. As we mentioned, there's a lot of variability in individual measurements on an EKG, but I think there's a couple of pharmacokinetic approaches to take here if you're initiating a medication. If you're going to start a medication that's maybe a one-time or just occasional short-term medication, you might want to think about how the medication at its peak dose is going to affect the QT interval. So understanding the time to peak dose and then taking or measuring an EKG at that time would be a reasonable approach. Alternatively, if you're thinking about a long-term medication where you're more worried about a steady state concentration, then you want to think about half-lives, and usually about 5 half-lives to reach a maximum steady state. And at that point, it may be reasonable to check an EKG. Telemetry, we actually are really fortunate to have guidelines on this. So the American Heart Association has guidelines on when we should use telemetry in general, but also in particular when we're worried about QT monitoring. They give us 5 basic scenarios. The first is when we're initiating any antiarrhythmic or any medication known to increase the risk of torsades in the setting of other risk factors. So if you're just starting a medication with the risk, but they have no other risk factors, you don't need tele. But if they have also electrolyte abnormalities or some other underlying heart disease or something, then you might use telemetry. The second one is drug overdoses with any medications known to cause torsades, or if you don't know what the medication is. The third is congenital long QT syndrome in the setting of arrhythmia or other things affecting the QT interval, not just every patient who has a congenital long QT syndrome. The fourth is moderate to severe electrolyte derangements with other risk factors, so maybe with QT drug prolonging medications. And then the fifth is in the setting of targeted temperature management, again, thinking about hypothermia as a risk factor here. So I'm going to skip over this slide and actually just jump to the last slides. And so Dr. Chatterjee was my main mentor for this talk. He's one of the electrophysiologists at Montlake. And I asked him specifically, when are you concerned? And he told me that he believes the transposition of risk in genetic long QT is really the most helpful strategy for risk stratifying. He believes that risk increments beyond 500 and acutely so after 550, and that for anyone whose baseline is over 500, he would have very strong reservations around QT prolonging medications. Now, obviously, we've all been in situations where we're stuck, where we feel like we need the medication for this patient. And in that case, I would advocate for a process of informed consent. Another way to think about this is almost exactly how we think about anticoagulation, because we know we often start anticoagulation in patients who are at risk for bleeding. But we do so via a process of informed consent with the patient, continuous evaluation or reevaluation of risk and benefit. And I think that that would be a reasonable approach for QT prolonging drug therapy. We see it sometimes in patients who have severe nausea and vomiting and just want the medications because it makes them feel better. And it might not be wrong to talk to them about what the risk actually entails rather than just saying no. And if they choose that that risk is something that they're okay with, then maybe you consider it. I think this is a case-by-case discussion. So to review, QT interval is imperfect. It might be the best we have right now. You have a certain number of tools you could consider using. So in your cardiac population, the Tisdale risk score. In other populations, you can just use something like a QT nomogram. There are some resources for QT prolonging medications. Think about pharmacokinetics when you're getting your EKGs. Don't just give somebody a dose of the medication and check an EKG at a random time because it may not correlate with the peak effect. We have guidelines for telemetry, and then consider a risk and benefit approach. And that's all I got. Happy to answer any questions.
I think if it's okay, we'll let the folks who don't have questions take a quick, maybe we'll say we'll start at 9:55 and the rest of the folks who have questions can hang out and chat.
Okay.
David, I was curious, who do I send the patient that I'm concerned for long QT syndrome after they get like discharged from the hospital, they had an EKG with QT? Am I sending them to EP? Am I sending them to genetics?
Yeah, it's a good question. I didn't actually ask Dr. Chatterjee, who's an EP, that question. I think it would be very reasonable to send that person. So I guess I would say first, it probably depends on your threshold of concern. But I think a reasonable first screen could just be general cardiology. In a lot of places there isn't even EP, and so I think it wouldn't be wrong to just start with general cardiology, who would have more experience triaging this than us probably, and could make the decision around like a genetics or EP evaluation. And in particular, I know at Montlake or at UW, we have a couple of cardiologists who specialize in like cardiogenetics, oftentimes thinking about things like HOCM and other syndromes. And I just don't know where long QT falls, if it like all goes to EP regardless, or if the cardiogenetics folks do that. So I would probably just start with general cardiology.
Cool. They'll triage it to the right place, I'm
Hey,
sure.
the fellow's got to see it, right?
Yeah.
May I ask who's going next?
It's me.
Annie, I have to apologize. I'm gonna have to step off. I wish I could watch your I'm gonna watch
No.
I'm
Okay.
gonna watch a little bit of it, but it turns out that I have a new job that I have to prepare for.
Oh, is that right?
Sorry.
That sounds good.
I'll be on for the first 10 minutes or so, but I if you saw me disappearing, it's not because I'm not engaged.
Okay. Thank you for specifying, because I truly would have wondered where you went. So thanks for being here. I'm sharing my screen and now I'm going to go into present mode. Will, can you tell me,
Yeah.
can you see my
What we can
slides?
see is the full website.
Still whole website?
Yeah, so I'm not getting a view of just the slide.
Huh.
I can help out if you'd like.
Okay, wait, and I can do one thing I can try to do. One thing is I can do this special. Okay, I'm gonna stop sharing. I'm going to put this on in my screen. I'm gonna press escape once.
Do you have notes?
I don't think I really need to see my notes.
Okay, so I can show you how to share them so that you can see your notes, but that we cannot, if you would like.
Okay, that's okay. I
Okay.
more just want them to only see the slides. I am like mine is in like present mode right now on mine.
Okay, great. So you want to click the share screen button,
Okay.
and then you want to share the presentation, not like the
okay.
screen, right? Share the presentation. And then at the top, you'll see it'll say like basic or advanced, and you want to click advanced, and you want to
Okay.
share the portion of your screen, and a little green box will pop up, and that box you can reshape and drag to just the slide that you want us to see.
Okay, I guess the one issue, Javel, is that as soon as I go into like truly present, then I can't get back to the. Okay. Let me try this one more time. Oh, advanced. Interesting. Okay, you're seeing the whole website now.
Yep.
And when I do this, 1 second. No. You're still seeing the full website.
Yes.
I can see it.
But I guess, okay. Cause then once I'm here, Javel, and I have it in like present mode, it won't now let me just go back to sharing part of it.
Did you see the green box when you clicked share portion of the screen?
No. Okay, let me try this one more time. Thanks everyone for your patience. Okay. Tim, share. Advanced, share portion, share. I see the green box.
So you can reshape that green box to just cover. the-
Yeah. Oh, okay. And it does look like it. Oop, doo-doo-doo.
Yeah, we can't see the full slide. We are
Yeah, I know.
looked at the
I'm trying
bottom.
to get it to, oh yeah, here we go. And now I just need to get my participants out of the way.
All right, that looks fairly good. I'm gonna give you an intro.
Okay.
So Annie's a graduate of our program now a couple years ago, and is currently a GI, soon to be in the hepatology track of her 3rd year, and recently fell in love